You know that feeling when you're just not feeling great and suddenly even your favorite food sounds meh?
Oh, yeah, absolutely. We've all been there.
Well, today we're doing a deep dive into what's actually going on inside your body when that happens, when that, desire to eat just disappears.
Exactly. And we're looking beyond just like the everyday, oh, I'm not that hungry right now. We're really exploring the biology behind appetite loss, the broader mechanisms, sometimes called anorexia in a medical sense, but separate from the specific eating disorder, you know.
Right, understanding the why.
Yeah, the why behind losing your appetite.
We've got some really detailed sources here that help unpack how our brains and bodies actually talk to each other about hunger and fullness.
And maybe more importantly, all the different ways that whole system can, well, go haywire.
Our info covers the definitions, the underlying biology, which is pretty complex, the symptoms, the huge range of causes, and even diagnosis and treatment approaches.
So the mission today, really get a handle on the key things influencing appetite.
And help everyone understand that difference between genuinely not wanting to eat versus having trouble actually eating.
Which is a crucial distinction.
Yeah.
And just showing the sheer breadth of things that can knock this fundamental drive off kilter.
Okay, let's jump in. When we talk about anorexia in this context, what's the basic definition we're working with?
So at its core, it just means a lack or loss of appetite for food. Simple as that.
But you mentioned it's important to separate a couple of ideas there.
Right. We need to distinguish psychological appetite, that's the desire or craving for food, from physiological hunger, which is your body's actual physical need for energy.
Okay.
And anorexia itself can be partial. We call that hyperexia, just a reduced appetite.
More complete.
Or complete, yeah. Total loss of appetite. Either way, it leads to eating less, and usually weight loss follows.
That makes sense. But then there's this other term you mentioned, pseudoanorexia. It sounds kind of counterintuitive.
It really is interesting. Pseudoanorexia is where someone does want to eat the appetite, the desire is there,
Mm-hmm.
but they physically can't. Like,
Wow.
they can't grasp the food properly, or they can't chew it, or they can't swallow it.
So it's a mechanical problem, not a desire problem.
Exactly. It's not about wanting to eat. It's about some physical barrier preventing it. And that's a real aha moment, because it tells us not eating isn't always about a lack of appetite. It could be something else entirely.
Yeah, you could easily assume someone just isn't hungry, but the reality is different. So, okay, if pseudoanorexia is about the mechanics, what is happening biologically when appetite genuinely dips? What's the control system?
Right. So appetite control is this incredibly um, complex dance. It's mainly orchestrated by the central nervous system,
Brain.
primarily, yeah. Specific areas in the hypothalamus and the brainstem act like central command centers or input stations
Input stations for what?
for all sorts of signals. They process sensory information, how food smells, tastes, looks, and metabolic signal.
Metabolic meaning,
Right.
like the energy levels.
Exactly. Signals that tell the brain about the body's current energy status. These stations then talk to other brain regions, creating this whole network that regulates our drive to eat.
Okay, let's break down the signals. Sensory ones first. What are we talking about beyond just taste and smell?
Well, taste and smell are huge, obviously. Think about having a cold food just isn't the same, right?
Definitely right.
But also texture, even the temperature of the food matters. And then there's the physical feedback, the feeling of your stomach stretching, gastric distension, and your upper intestine, the duodenum stretching too.
The I'm full signal.
That's a big part of it, yeah.
Yeah.
Sends a message back saying, okay, tank's getting full. So it's the initial appeal plus the physical consequences of eating.
And the metabolic signal sounds more internal, like body chemistry stuff.
Precisely. These are the chemical messengers, peptides, hormones that your body releases. Depends if you're fasting or if you've just eaten.
Like insulin.
Insulin plays a role, yes, but also things like your blood sugar, your glucose levels, and the levels of fatty acids circulating. These interact with receptors, particularly in the liver and the GI tract, and they ping the brain about energy availability.
So who are the main chemical messengers in this appetite orchestra? Who shouts eat and who shouts stop?
Good way to put it. There are several key players in this sort of hormonal tug-of-war.
Okay.
Got leptin. It's mainly made by fat cells. It basically tells the hypothalamus, hey, we've got plenty of energy stores, so it decreases metabolism and appetite.
So more fat, more leptin, less hungry, generally speaking.
Generally, yeah. Then on the flip side, you have neuropeptide Y, or NPY. comes from the gut, among other places, simulates hunger, makes you want to eat. Its levels go up when you haven't eaten for a while.
Makes sense.
Then there's ghrelin, often called the hunger hormone.
Heard of that one.
Yeah, it's made in the stomach. It cranks up hunger signals. Interestingly, it also seems to decrease leptin and increase NPY. So it's really pushing the eat now button.
Wow, okay. Any others telling us to stop?
Yep. Cholecystokinin and CCK and bombesin, also from the GI tract, they get released after you eat and signal fullness, suppressing appetite.
So it's ghrelin and NPY saying go, and leptin and CCK saying stop. A constant battle.
Pretty much. It's a dynamic balance.
What about neurotransmitters like serotonin and dopamine? We hear about them for mood, but do they play a part here?
They absolutely do. Serotonin acts centrally in the brain, and it's a really key mediator in appetite control, often associated with satiety, feeling full.
And dopamine, the reward chemical.
Yep, dopamine's involved too, linked to the motivation and reward aspects of eating. It helps regulate food intake, partly through that pleasure pathway. It ties food seeking to feeling good.
Fascinating. So it's biology, but also pleasure and habit. What about external stuff? Like, can our routines override these internal signals?
Oh, hugely. Environmental factors are incredibly powerful. Think about meal timing. Just seeing the clock strike noon can make you feel hungry, right?
Guilty as charged, yeah.
And where you eat, learned behaviors like always having popcorn at the movies.
Right.
Even our body's natural 24-hour clock, the circadian rhythm, all these things can modulate, sometimes even completely override those internal hunger and fullness cues.
That's wild. So habit can be stronger than hormones sometimes.
It definitely can seem that way.
Yeah.
And other hormones, beyond the specific appetite ones, chip in too.
Like what?
Hormones like aldosterone and corticosterone can actually increase appetite, while others like glucagon and somatostatin tend to suppress it. So the body's overall hormonal state matters.
Okay, now the big one for many people, getting sick. Why does appetite just vanish when you have the flu or something?
Yeah, it's such a common experience. When your body's fighting inflammation, like from an infection or dealing with something like neoplastic disease cancer, it releases these potent molecules called pro-inflammatory cytokines.
Okay, fancy name.
Huh? Yeah. Things like interleukin-1, tumor necrosis factor, interferon. These directly impact the brain and can significantly decrease appetite.
So the body's prioritizing fighting the illness over eating.
That seems to be part of it. It's like resources are being diverted. Interestingly, with cancer cachexia, that severe wasting, the body should be screaming for more energy, but these cytokines often suppress that drive to eat.
Wow. And it's not just infections, right? Toxins can do this too.
Absolutely. Both toxins you might accidentally ingest, external ones, and toxins that build up internally if organs aren't working right.
Like kidney failure.
Yeah, exactly. Kidney or liver failure.
Yeah.
Those waste products can dampen appetite. Also, anything that just generally lowers your level of alertness, your cerebral arousal, that can lead to eating less too.
And you mentioned gastroparesis, stomach emptying slowly.
Yeah, if the stomach isn't emptying properly, often due to another underlying condition, that feeling of persistent fullness can definitely kill your appetite.
And I guess emotions must play a huge role too. Stress, pain.
Well, for sure. Your emotional state is tightly linked.
Yeah.
Fear, significant pain, high levels of stress. They are all well-known appetite suppressants for many people.
Okay, so we have this incredibly complex web of factors. Given all that, how do we start recognizing when an appetite issue might be a real problem? What are the signs?
Well, the most obvious sign people report is just, refusing to eat.
Makes sense.
But we have to keep circling back to that pseudo-anorexia distinction. Is the person refusing food, turning away? Or are they showing interest, maybe approaching the food, but then physically struggling?
Right. Showing desire but inability.
Exactly. Pain when trying to eat, difficulty chewing or swallowing, dropping food. Those are clues. It might be pseudo-anorexia. They want it, but they can't manage it.
That's such a key difference to spot. Any other signs that might pop up?
Well, sometimes a loss of the sense of smell and anosmia can be involved. If food doesn't smell good, appetite often drops.
Yeah, I can see that.
And of course, the most general sign over time is weight loss. If intake is down consistently, weight will eventually follow.
And during a physical exam, what might a doctor or vet look for?
Oh, it really depends on the suspected cause. Could be anything from fever, paleness, jaundice, that yellowing, signs of pain, maybe finding enlarged organs, abdominal swelling, breathing issues, abnormal heart or lung sounds. Obvious weight loss or muscle wasting if it's been going on a while.
Okay.
And specifically for pseudoanorexia, they'd look for things like bad breath, maybe excessive drooling, obvious difficulty handling food, signs of pain when swallowing, That's called odynophagia.
Got it. Those pseudoanorexia signs seem quite specific.
Uh-huh.
Okay, let's dive into the why even more. Our sources mentioned a vast range of causes for true anorexia or hyperexia.
Oh, the list is huge. It really underscores that loss of appetite is usually a symptom, not the disease itself.
Can we group them somehow?
Yeah, we can try.
Yeah.
First, there are psychological or environmental factors. Maybe the food just isn't palatable, or there's a food aversion from a bad experience. Stress is a big one, changes in routine, new environment.
Okay.
Then pain. Any significant pain, anywhere in the body.
Huge category.
Massive. Then toxicities, poisons, drug side effects. Very common. And then you get into systemic diseases. Problems with the GI tract, obviously. Acid-base imbalances, heart disease, endocrine or metabolic issues like diabetes or thyroid problems. Cancer, so neoplasia. Infections, bacterial, viral, fungal. Immune-mediated diseases where the body attacks itself, respiratory problems, musculoskeletal issues causing pain or discomfort, neurologic diseases, and even miscellaneous stuff like motion sickness or just being too hot. High environmental temperature can really suppress appetite.
That list is staggering. It could be almost anything.
Pretty much. It highlights why figuring out the why is so critical.
And the specific causes for pseudoanorexia, where the desire is there, but the mechanics fail.
Right. Those relate directly to problems with picking up, chewing, or swallowing food. So issues in the mouth, stomatitis, inflammation in the mouth, glossitis, tongue, gingivitis, gums.
Makes sense. Painful mouth equals no eating.
Exactly. Problems in the throat or esophagus. Pharyngitis, esophagitis, that could be from injury, chemical burns, infections, foreign objects stuck there, immune issues. Things behind the throat, enlarged lymph nodes, abscesses, tumors back there. Dental disease is a huge one. Periodontal disease.
Very common.
Yep. Even an abscess behind the eye, a retrobulbar abscess, can cause enough pain. Cancer anywhere in the mouth, throat, esophagus. Neurologic problems affecting the cranial nerves that control chewing and swallowing.
Ah, nerve damage.
Right. Or brain lesions affecting those control centers. Muscle diseases affecting the chewing muscles like masticatory myositis or problems with the jaw joint, the TMJ, and even salivary gland issues, inflammation, tumors.
Again, a long list, but very focused on that physical process of eating.
Exactly. Pain or dysfunction in that pathway.
So, faced with this massive list of possibilities, how does a medical team even start the diagnostic process?
It really has to start with a super thorough assessment. Getting a detailed history is key.
Like what?
Diet history, what do they normally eat, what are they eating now, how much, what's their normal body weight and condition, their muscle mass.
Okay, establishing a baseline.
Exactly. And really probing about any recent changes, environment, routine, stress levels, trying to uncover those potential psychological triggers.
And then observation.
Crucial. Watching the patient interact with food. Are they interested? Do they approach it? Or do they ignore it? If they try to eat, what happens? Do they struggle? That helps differentiate true anorexia from pseudoanorexia right off the bat.
That seems like a really important step. What comes next?
A complete physical exam, head to tail, paying super close attention to the eyes, mouth, throat, face, neck, especially if pseudoanorexia is suspected.
Might need sedation for a good look.
Sometimes, yeah. To really get in there and examine the mouth and throat properly, sedation or even light anesthesia might be needed.
Okay, then tests.
Usually starts with baseline tests, blood work, a CBC, complete blood count, and a serum biochemistry panel to check organ function, electrolytes, proteins, etc. A urinalysis.
Standard stuff.
Pretty standard initial screen, yeah.
Okay.
Depending on where the suspicion lies, maybe specific tests for infectious diseases like heartworm or retroviruses.
And imaging.
Often necessary. X-rays or ultrasound of the abdomen, the chest, maybe the neck area, to look for abnormalities, masses, foreign objects, organ changes.
What about looking inside directly?
Endoscopy can be really valuable, using a small camera to visualize the pharynx, esophagus, stomach, maybe even the intestines. You can sometimes spot inflammation, ulcers, masses, or foreign bodies that way.
And biopsies.
If abnormal tissue is seen, yes. Taking small samples, biopsies, or fine needle aspirates for microscopic examination is often needed for a definitive diagnosis, especially for suspected cancer or certain inflammatory conditions. It's detective work, piecing all the clues together.
Sounds like it can be quite involved. What if, after all that, the team suspects it is just psychological, like stress or food aversion?
That's often called the diagnosis of exclusion, meaning you've done a reasonable workup to rule out the major medical causes first.
You don't jump to psychological.
Exactly. You need a solid basis, history, exam, initial labs that strongly points that way before you stop looking for a physical cause. And even then, You need very close follow-up.
To make sure you didn't miss something.
Right, to ensure the appetite does return as expected and that no subtle medical issue emerges later.
Okay, so let's say a cause, or at least a likely cause, is found. What's the game plan for treatment? How do you get them eating again?
Priority number one is always treat the underlying disease. That's the fundamental goal.
Address the root cause.
Absolutely. Treat the infection, manage the organ failure, control the pain, remove the tumor as possible, whatever the primary issue is.
And in the meantime, while that's happening,
Supportive care is key to encourage eating, making sure they're hydrated, correcting electrolyte imbalances. Managing any pain or nausea effectively is huge.
makes sense. If you feel sick or hurt, you won't eat.
Exactly. Reducing stress in the environment can help too. And then focusing on the food itself, making it more palatable.
How do you do that?
Simple tricks sometimes work. Warming the food slightly can release aromas. Adding things like low-sodium chicken or beef broth for flavor. Sometimes just adding water to dry food helps. Adjusting the texture, maybe offering canned food, increasing fat or protein content within reason can enhance appeal.
Trying different things to tempt them.
Basically, yeah. See what works for that individual.
What about those learned food aversions you mentioned? If they associate their regular food with feeling sick?
That's tricky. You have to be cautious. Reintroduce food slowly. If they show any aversion turning away, lip smacking, signs of nausea, remove it immediately. Don't push it.
Might create a stronger aversion.
Exactly. Sometimes offering a completely different novel food source that they've never had before can bypass that learned aversion.
Ah, something totally new.
Yeah. And always review their current medications. Are any of them known to potentially suppress appetite? Maybe a switch is needed.
Good point. What if they're really malnourished or just won't eat enough despite these efforts?
Then assisted feeding often becomes necessary, especially if they've lost significant weight, have low protein levels, poor condition, muscle wasting, or just haven't eaten properly for, say, 3 to 5 days.
How does that work?
Two main ways. Enteral nutrition, which uses the gut.
Feeding tubes.
Yes, various types of feeding tubes can be placed nasogastric, esophageal, gastric tubes, depending on the situation and how long support is needed. This delivers liquid nutrition directly into the GI tract.
And the other way.
Parenteral nutrition. That's intravenous feeding, delivering nutrients directly into the bloodstream, bypassing the gut altogether. Right. Used if the gut isn't working properly.
Is force feeding ever okay?
Generally, no, especially not in cats. Force feeding can easily create severe food aversions and make the situation much worse. Assisted feeding via tubes is much safer and more effective when voluntary intake isn't enough.
Got it. Are there actual medications to stimulate appetite?
Yes, there are a few options that can be tried in specific situations, under veterinary guidance, of course.
Like what?
Drugs like mirtazapine or cyproheptadine are sometimes used. They work on certain receptors in the brain to increase hunger signals. Sometimes benzodiazepines like diazepam or oxazepam are used short-term, but they can cause sedation.
So options exist, but need careful use?
Definitely. And again, treating underlying issues like pain with appropriate analgesics or addressing poor gut motility with prokinetic drugs like metoclopramide or managing nausea with antiemetics like meropitant. That can indirectly but significantly improve appetite too.
But you need to be careful with some of those.
Absolutely. For instance, you wouldn't want to use a prokinetic drug if you suspect a gut obstruction. And sedatives need extreme caution in already weak or debilitated patients. It's always a risk-benefit assessment.
So it's really about tailoring the approach. And once treatment starts, how do you track progress?
Monitoring is critical. Regularly checking body weight is essential. Assessing their body condition score and muscle condition score over time. Monitoring hydration. And actually quantifying or estimating their caloric intake. Are they eating enough to meet their needs now?
Keeping close tabs.
Yep. And long-term prevention, where possible, focuses on keeping them comfortable, managing any chronic conditions well, and ensuring their diet remains highly palatable.
What happens if anorexia isn't addressed effectively? What are the risks down the line?
The complications can be really serious. Prolonged lack of nutrition leads to dehydration, malnutrition, and eventually cachexia, that's severe muscle wasting.
Which weakens them further.
Exactly. It compromises the immune system, making them more susceptible to infections. Muscle weakness can become profound, even affecting breathing. In obese cats specifically, sudden anorexia carries a high risk of a serious liver condition called hepatic lipidosis.
Nasty stuff.
Yeah, and severe malnutrition can even cause the lining of the intestines to break down, which can lead to bacteria leaking into the bloodstream. Ultimately, depending on the cause and severity, untreated anorexia can unfortunately be fatal.
That really underscores the importance of figuring it out.
Yeah.
So the overall outlook, the prognosis.
It really truly depends entirely on the underlying cause. Because anorexia is almost always a symptom, the prognosis hinges on whether that primary problem can be identified and successfully treated.
Right. Treat the cause, resolve the symptom.
That's the goal.
Okay, so wrapping up our deep dive today, it's incredibly clear that appetite control isn't simple at all. It's this amazingly complex interplay: physical signals, psychological factors, hormones, nerves.
A really delicate balance.
Yeah.
And what seems like just not wanting to eat can stem from this huge spectrum of issues, from subtle biological shifts to major systemic diseases.
And that distinction we kept coming back to, true lack of appetite versus a physical inability to eat, pseudoanorexia, that's such a crucial piece of the diagnostic puzzle.
Absolutely, direct the whole investigation.
Yeah.
And just seeing how many different body systems feed into regulating this basic drive, it really highlights how interconnected everything is.
It really does. And thinking about this intricate web of signals, it
Yeah.
kind of makes you ponder the deep connection between our physical health and our emotional state, doesn't it? Like, how much are our daily habits, our stress levels, our environment, how much are they subtly nudging this fundamental drive one way or another, maybe without us even realizing it?
That's a fantastic question to reflect on. It reminds us that understanding our own bodies, or those we care for, is really an ongoing journey, isn't it?
It really is. So if anything we talked about today sparked your curiosity, definitely dig deeper into those areas. Learning the language your body uses is always time well spent. We hope this deep dive gave you some valuable new insights.